Jazakallah. Over to you, Dr. Aisha.
Jazakallah. So I believe there is some connection problem which Dr. Javed Iqbal is facing. So till he comes on board, I will perhaps start sharing his presentation myself so that we can begin and then he can continue whenever he gets connected. So kindly, Saad, if you can facilitate him to get online.
Sure, sure. I'll.
Okay, so Dr. Javed Iqbal is a consultant sports surgeon and working as assistant professor at Medical Teaching Institute, with Lady Reading Hospital. So this is a big tertiary care hospital with a very multi-dimensional, diverse kind of orthopedic department. And I believe this is the biggest teaching and clinical facility which is in the northern province of Pakistan, that is KPK, Khyber Pakhtunkhwa. So in this article, he has actually talked about the functional outcome after arthroscopic reconstruction and also talked about his post-op physiotherapy protocol. So I think it will be nice if I can present directly from his article. So meanwhile, as we get Dr. Javed Iqbal on board, I will just give you an introduction of our very able and renowned expert for today, who is Dr. Kamran Butt. He is a consultant orthopedic surgeon and consultant sports surgeon from Pakistan. And I believe most of you already know him. He has a really, really long introduction, but I'll try to do justice, but then I have to read it from a source. So he is FRCS and FE-BOT, trauma and orthopedic. He is also diplomat sports medicine of Ireland. He has a fellowship of hip arthroplasty from London, and to my own pleasure, he also has a fellowship in children orthopedic from Manchester. He is a European board qualified orthopedic surgeon. He has 15 years of experience from Ireland and UK. He's also ex-consultant from Birmingham, UK. He trained in shoulder, knee, ankle arthroscopy surgery, and he also has a fairly good experience with children orthopedic trauma and joint replacement. His special interests are minimally invasive arthroscopic surgery, one of the pioneers in this field of Pakistan, and he's also the founder of Orthopedic Sports Medicine Center in Lahore, Doctors Hospital, Pakistan. So welcome, sir.
Thank you very much, Aisha. I mean, it's I never realized, that I have so much intro. It's like a great meeting to start with. I'm seeing the guys are waking up. It's like a mini marriage proposal of an orthopedic surgeon. So anyway, we should get on with it. I am here. The best thing is the day I start teaching, the day I start learning. So I'm enthusiastic. I'm going to learn something from this meeting, and you guys have done a wonderful job with Faz there as well, that try to organize, and I guarantee you it's worth getting up in the morning. I got up anyway 5 o'clock, but it's worth. So let's start, and thank you very much for the introduction.
Thank you, sir, for joining. You are a pride for our country, and we are really thankful that you joined us, and it makes a great difference when you are around. So Dr. Javed Iqbal is here. Kindly share your screen.
Madam, are you hearing me? Are you hearing me?
So, yes, we can hear you. Kindly share your screen and start presenting since we have already done the introductions.
I also request you to please elaborate the process of asking question, answers, and comments.
Yeah. So meanwhile, I will request the audience that if they have any queries, they can use the chat box. They can post their questions over there. And because our format is so that for the first 20 minutes, Dr. Javed Iqbal is going to give his presentation, followed by a 10-minute review by our expert. And following that, we will do an answer question session. And I will also give opportunity to the people who are attending this webinar to ask directly. So kindly be patient for your turn, and you can always use the chat box and I can forward the question. So over to Dr. Javed Iqbal. Kindly share your screen.
मैडम देयर इज ए प्रॉब्लम मेरा जो मतलब मैं मोबाइल से कनेक्ट हूँ और उससे कनेक्ट नहीं होता
Okay, I will share the screen for you. Okay, so you can present and I will move it forward. So I am forwarding your presentation. I've given your introduction already. So let's start from the first slide.
Okay, thank you so much. First of all, I am really sorry for delay in my connection, delay in my arrival because there was some technical problem in the net. So I am Dr. Javed Iqbal, as already introduced by the madam. I am consultant orthopedic surgeon and a super specialty sports fellow. And by this time, I'm working as assistant professor in the medical teaching institution Leader in Hospital. Next slide, please. First of all, how we will proceed for this today's general club. I will briefly introduce what are the variables in this study project that we have done. And after that, I will present my article title, then the methodology, and then I will proceed with the results, the discussion, the limitations and usefulness of my study. And at the end, we will conclude our study, inshallah. First of all, what are the variables in my study? That is basically my study was about the ACL injury and its arthroscopic reconstruction with physiotherapy, post-operative physiotherapy protocol. So we will pick one by one. So first of all, what is ACL injury? As you all know, just to recapitulate your knowledge, ACL is a ligament of the knee joint, and it provides stability to the knee joint in the anteroposterior plane, that it prevents anterior translation of the tibia over the femur. Likewise, it provides rotary stability, that is, it prevents the internal rotation of the tibia over the femur. When the ACL gets injured, the deficient ACL deficient knee becomes unstable, and all the mechanics of the knee joint gets altered, which leads to suboptimal function, the cartilage and meniscal injuries, and at the end, early degenerative arthritis of the knee joint. Next slide, please. So for the ACL deficient knees, arthroscopic ACL reconstruction is the gold standard method. And what we are doing for the ACL reconstruction, our ACL reconstruction is as anatomical as possible. The graft of the ACL that is fixed on the femoral side by the suspensory mechanism, that is the endo button, and on the tibial side, we are using the bioabsorbable screw. Next slide, please. Now, the graft choices for the ACL reconstruction, there are multiple choices. There is hamstring graft, bone patellar tendon bone graft, peroneus longus tendon graft, there is quadricep graft, and the allograft, and the synthetics. Next, please. After the ACL reconstruction, the physiotherapy protocol is very, very important, as you all already know. And we have got two protocols. That is, one is supervised physiotherapy protocol that is hospital-based. And we have got another protocol, that is online video rehabilitation protocol, in which a video program is given to the patient, and the patient follow that protocol at their house. Next, please. Now, coming towards my original research, original article and original research, our research, the title of our research is the functional outcome of arthroscopic reconstruction of anterior cruciate ligament using quadrupled hamstring autograft and endo button with supervised post-operative physiotherapy rehabilitation protocol in men. Next, please. I am the principal author of this study. And other authors are Dr. Umar Bhatt, who is basically the super specialty sports program in Pakistan, and who is working at the JPOA Hospital, Karachi. And he's also working at the National Hospital, Lahore. And likewise, he is also working in the Circlebath Hospital, UK. The next author is Dr. Zishan Khan, and he is the consultant orthopedic surgeon. And by this time, he is working as assistant professor in the Hyderabad Medical Complex, and he's orthopedic oncologist. Likewise, Dr. Zainab Khan, who is basically the research lead and who is biostatistician and the head of the research department at Hospital, Karachi. Likewise, other authors are Dr. Faizan, who is doctor in physiotherapy, and Dr. Behram Sidwa, who is medical officer there in a hospital in Karachi. In the start of our study, we hypothesized that arthroscopic reconstruction using quadruple hamstring autograft and endo button yields better result. We also hypothesized that post-operative supervised physiotherapy rehabilitation. Next, please. Next, please. Madam, next slide, please. Yes. Basically, our study, it was a retrospective analytical case series study, and a total of 79 patients was included in this study, and it was conducted from 2016 to 2018 at the JPOA Hospital, Karachi. Next, please. A total of 79 patients, all were male, and there was no associated meniscal cartilage, previous surgery, multiligamentous injuries, and all those patients were included in the study who underwent 6 weeks post-operative supervised physiotherapy rehabilitation protocol. Next, please. And all the other patients who has got meniscal injury, cartilage injury, multiligamentous injury, contralateral side injury, and already whose surgery was done, that was excluded from the study. And pre-operative and post-operative outcome measures were established, and these measures are activity level of the patient, stability of the knee joint that was assessed by means of Lachman inferior draw and pivot shift test. The other variable was range of motion, pre-operative and post-operative. The next variable was Tiger that was measured. Other variables were IKDC International Knee Documentation Committee score and Tigner-Licholm score. And the next variables were single leg hopping. Next, please. As far as the activity level was concerned, the patients were divided into 3 groups. That is group A, that was strenuous activity level group, that is highest activity level. All the sportsmen that who are playing sports like hockey, soccer, football. In the group B, the patient were with moderate activity level like running, jogging at least 5 times a week. That was included in the group B. And in the group C, that is light activity, people were included in this study, that is who are doing household activity, office work, cooking, and just like walking. These people are included in the group C. Next, please. The preoperatively, all the patient underwent history examination, all the relevant investigations were done, and data was collected for the study purpose. Then, after optimization of the patient for anesthesia in a surgery, all the patient underwent surgical intervention in the form of arthroscopic arthroscopy was done, and in the arthroscopy, as anatomical as possible, single bundle ACL reconstruction was done. The graft was the hamstring autograft that was quadrupled, and that was fixed on the femoral side by suspensory mechanism, that is endo button, and bioabsorbable screw was used on the tibial side. Next, please. This is the post-op X-ray, and one thing which is only visible, that is on the lateral outer surface of the lateral cortex, endo button is lying, which is radio opaque. Otherwise, nothing is visible. This is the beauty of this surgery, which is basically the recent advances in the ACL reconstruction to use bioabsorbable screw as compared to that of metallic screw, and on the femoral side to use the suspensory mechanism. All the surgeries were done by the single surgeon, that is Dr. Umar Bhatt, who was basically the surgeon for all the cases. And all the cases was done with the same protocol, that is quadruple hamstring autograft that was harvested from the medial side of the same knee, and the graft was then fixed on the femoral side by suspensory mechanism, that is endo button, and on the tibial side we use bioabsorbable screw, which is not visible in this case. Next, please. Then after surgery, then all the patient underwent 6 weeks post-operative physiotherapy hospital-based program. Next, please. Sorry, this is a very busy slide, but this is basically the hospital-based post-operative our physiotherapy protocol that we passes the patient into 4 phases. In the phase 1, basically this extends over first week, and in the first week we are using ice packs to reduce pain and swelling, static assisted SLR, ankle pumps, and static quads. Then the patients are mobilized with the non-weight bearing for 2 to 3 days with the help of crutch. Then we allow the patient to bear weight up to 40% for 10 days. Then for the next 3 weeks, the weight is increased up to 80%. And at the end of 1 month, we mobilize the patient with full weight bearing after 1 month. Likewise, in the second phase, extend from 2 to 9 weeks. The third phase extend from 9 to 16 weeks, and the fourth phase of the physiotherapy extends from 16 to 22 weeks. Next, please. The results of our study, there is total of 79 patients were included in the study, and the age range of that patient extends from 18 to 40. That was the average age was 25 years, and all the patients were male. The beauty of this study, is the sample size extends all over Pakistan. As you know, we are practicing orthopedics in a hospital, Karachi, where we are draining basically patients from the Sindh and from Balochistan, and in Lahore we are operating the patients of Punjab and the KB. So basically, this is the sample size extending all over Pakistan. Then we followed the patient at 3 months, 6 months, and 12 months. And what were the outcome measures? We assisted outcome measures on the post-op visits. That is, we assist the knee stability by means of knee stability test. That is Lekman, interior draw, and pivot shift test. And all the tests were negative at follow-up periods. Then we assist the range of motion of the patient after surgery, and the range of motion of the knee joint, of the operated knee joint, become normal after 3 months. Then the knee thigh girth was assessed, and we found that there was no statistically significant difference in the operated side and the contralateral side after 1 year of the surgery. Next, please. Next slide, please.
Okay. Yeah.
One slide back. Yes. Then the patient reported outcome measures that was assessed by means of International Knee Documentation Committee score, that is IKDC, and Tigner-Leishlam score. These 2 scores were applied at every follow-up, and there was a significant improvement in each and every follow-up. And there was a statistically significant difference. That is, at each follow-up, the p-value was less than 0.05. So it means that there was a significant improvement in the each score at each follow-up. That is, coming to the IKDC score, the mean preoperative score was 38.95. And post-operatively, we assessed and we found that the IKDC score at 6 months was 67.92, and at 12 months, it increased up to 90.73. Coming to the Tigner-Leishlam score, the mean preoperative score was 51. Post-operatively, at 6 months, it was 87, and at 12 months, it increased up to 97. Next, please. Coming towards the activity level, the resumption of the activity level in the group A, in which the sports people were present in our study, after 1 year, all the patients resumed their pre-injury sports activity level after 1 year. In the group B, all the patients with moderate activity level, that is, who are doing jogging, running at least 5 times a week, these patients resumed their pre-injury status after 9 months after surgery. And in the group C, all the people with light activity, that is household activity, office yard activity, these people and these patients resumed their pre-injury status at 3 months. Next, please. Next, yes. Coming towards the discussion, first of all, to discuss about the hamstring autograft, we used the hamstring autograft in our study, and that was fixed on the femoral side with endo button and on the tibial side with the screw. We found in the follow-up visits that there was no laxity of the graft. The knee remained unstable, as I told, that the stability test, that pivot shift, neckman test, and interior draw test postoperatively all became negative. So the graft was tight enough and there was no laxity. And postoperatively, there was no interior knee pain or pain inside the knee joint. There was no significant reduction in the thigh girth after 1 year, and all the patient had complete range of motion at 3 months. It means that the hamstring autograft, if used properly, there is no anterior. One slide back, please. One slide back, please. So it means that the hamstring autograft, quadruple hamstring autograft, the patient having no knee pain, there is no wasting of the ipsilateral knee, and the range of motion, everything is okay. If we compare it with the bone patellar tendon bone graft, in which the graft is taken from the interior aspect of the knee joint, that is the patellar tendon, and a chip of bone is harvested from the patellar lower surface. Sometimes the patient is having anterior knee pain, because of which there is some reduction in the extension. There is slightly extension leg because of the pain. So in our study, we found no pain and there was no reduction in the range of motion. The extension was complete. And the after hamstring graft harvesting, there was no wasting of the ipsilateral thigh, which was basically assessed by taking the girth of the thigh after 1 year, there was no significant difference. So it means that the hamstring autograft yields comparable result as that of the bone patellar tendon bone graft. Next, please. Rehabilitation. Coming towards the rehabilitation, returns to sport are pre-injury status. It basically depends upon the range of motion. That is, the patient must have complete range of motion. The muscle girth must be, that muscle girth and strength must be enough to control and to have a proper proprioception of the limb, to allow the patient to assume the activity status. And there must be proper neuromuscular control. With the 6 weeks supervised physiotherapy protocol, we achieved all these targets in all our patients. And in our study, the 37% of our patients were sportsmen. And alhamdulillah, at the end of 1 year, with this supervised physiotherapy protocol, all the patients resumed their pre-injury sports activity level. Next, please. There are certain limitations of our study. The limitations are, this was basically a retrospective analytical, so we don't have any comparative group to evaluate hamstring supremacy over other graft. Basically, this is not a randomized controlled study or comparative study. So, and the follow-up period was 1 year. So we can't evaluate the long-term complications and outcome measures associated with the hamstring. And clinical trials are needed to evaluate the effectiveness of post-operative physiotherapy protocols. These are the limitations of my study. Next, please. However, this study provided us data which can be used as a frame for the future descriptive compared to any sorts of study in our population to standardize the treatment protocol as for the standard evidence-based orthopedics in the future. At the end, to conclude, arthroscopic ACL reconstruction using quadruple hamstring autograft as anatomical as possible with endobutton and bioscrew with supervised post-operative physiotherapy rehabilitation protocol leads to better functional outcome. Thank you so much. I'm sorry that there are some deficiencies in my slide as discussed with the madam, but I'm sorry for that.
Okay, so thank you very much for your presentation. Now we move to Dr. Kamran Bhatt. Sir, we will request you that you give a brief overview of this article and how you feel about it. And if you have any questions, you can put directly.
Thank you very much, Dr. Aisha, Dr. Faiz. And this is a show which I should say the hero is Dr. Javed Iqbal.
Thank you,
And
sir.
all our residents who are sitting there and feel me very proud, something which me, Marbat, and other people were doing in the Western world, we have started to do. So first of all, guys, try to take this that so far we have a habit of, alhamdulillah, everything is fine. But having a complication, having a problem is also surgery. So critique mean I have to go through positive and negative side. It's not negative. I shouldn't use the word negative. I have to tell you the salient feature, what you have done so good and what's lacking in the study. So you have to be very vertical and critical. It's a journal club. So you have to watch it if there is any bias or anything, confounding factors, study, hierarchy of research, whether it's the top one or the bottom one. So going to the good side for the hero, well done. Very good presentation, good command, seems like a good team providing a good service. Yes, he gave a very good brief account of all the factors starting from ACLs, the graft choice in terms of hamstring, the surgical side, and himself mentioned some of the limitation factor. If I will look into the study, first of all, I have to get my pre-biased off. I'm not biased. Lots of our residents sitting there talk very superficial that, oh, do you like a hamstring? Are you like a patella tendon? Are you like the button? Are you like the screw? So first of all, coming to the study and then to my own comment. The study is that, as you said, it'll be nice to have a comparative study. Somebody can easily critique you whether this is an audit or this is a retrospective audit of a single surgeon, or rather than actually study. So in terms of really, if you want to make an impact about an implant graft choice, you really have to have a comparison, right?
Yes.
Retrospective study, you have to look into it that, am I going towards the audit of a person or am I going towards the outcome of a person? So that's when, yes, you already mentioned in the end that there was a weakness. Second, I would say that the inclusion criteria has to be a little bit more prominent. We have a variability. If you look at our population, you can have easily a person coming after 7 years, pre-arthritic, degenerative, and others. It's a very hard to get proper inclusion criteria. So maybe that we have to put it down in a much better way, inclusion and exclusion criteria a bit more. So we know we exclude all those people who have 10 years following injury, people who are not fit into may have some arthritis there. So the guys sitting in a resident portion know which one is included, which one is excluded. The good thing and the other thing is that, yes, it was phenomenal, outcome for these studies, but confounding factors are there. It's a single surgeon. So it's not only the graft. So people sitting out there, it's great, but it's not the graft, it's the position of the graft. The material, which one are you using? Either is an aperture fixation, whether it's a suspensory fixation. So it really depends where you put it, cortical or aperture. So before you look into only one graft choice, you have to look at that's not the only factor. There are other confounding factors which affect your study. Who is operating? So in this, there is only one surgeon confounding factor, single operator doing all the operation. Second, there is not different implants being used. It's only one, probably material wise, maybe the company like is only a one company implant, a two company implant, or what money. So I'd be more interested to know the cortical fixation is done by this brand and this brand. And was there variation in the cortical fixation implants? Was it any variation in the endo button side? So just to say that, was there any confounding factors in terms of choice of material or not? The third is that yes, you have a loss of follow-up. It's too early in there. Outcome wise, I would have thought that you go for an excellent, good, fair, and bad. So if you're going to quantify in a research fashion, you have to say, well, I'm impressed from you and Umar Bhatt, like 100%. Fantastic outcome so far in a 1 year, which is fantastic, you know. I mean, well, I know where to go for ACL now, but I mean, this is the thing is that the guys sitting out there, phenomenal work, great work done by you and by the team. So when we come to the methodology of research, we really have to say which hierarchy we are standing at. So well done once again. I think pretty very good. P-value has been there. Stats why I'm happy. Lots of good scoring. Looks like a mature study. A lot of outcome scores has been mentioned. There's a lot of help. You have help from the physiotherapy combined. It's a teamwork. So we're very happy with that. And in future, we'll wish that you have a comparative prospective study, the amount of stuff you have that you can put in a different fixation device study, a study between graft choice, aperture, cortical fixation. With the, don't forget, we do lots of other implant and we have financial constraint in this country as well. But this is a beginning. It's not the end. Sky is the limit. So well done. For the resident who are sitting there, they love to because it's fantastic that we are going through this journal club. I'll leave the forum for the question answer. But there's lots of people who are very basic as well in answering questions in the exams and others. So when you're trying to make any opinion, don't be biased. No pre-bias that this is done in Reading Hospital or this is done in Lahore. No, you talk orthopedic. So the ACLs, really good ACL depend on the graft patient factors, then the graft factors, then the tunnel position, fixation factors, and post of rehab factors. So get this confounding ideas that it's not constrained that I put it. And don't fight only. When an examiner asks you a question, talk in a nice way. Sir, I would like to do this ACL. You need a symptomatic instability patient, young, indicated in ACL. My choice of implant, looking at patient factors. So coming to patient factors. Athlete, high demand, still the best graft is bone-to-bone healing. I have converted to hamstring. I've done my personal experience, patellar tendon. Lots of people in the audience have seen and been through patellar. Nothing wrong with the patellar tendon. Fantastic. Second, after patient factors, so I divide in a personal experience for guys sitting out there wants my opinion as well. As I said, I will give in the end. If you're a very high demand, really, then I'll go for a PTB. If you are otherwise, your hamstring quadruple glove is very good enough. Pakistan, especially for Pathan patients, nothing against, I love Pathan. The kneeling, the anterior knee pain, no, Baksha Nagwadam, you know, Baksha Nagwadam. So I would like to be, I mean, so get included that. Our patients are happy with this. We are proud of this presentation. I mean, there are tons of presentations saying the best one we all quote that they've quoted between PTB, hamstrings, all this fixation. They said all same. That's why it's called now, what you said is called now popular option. Agar aap mareej se sare puche, the popular option now will be hamstring, biological, anatomical, individualized, endo button with a bioabsorbable screw. A very popular option. So open your mouth, open your head. So this is popular option what you're doing, but no, this is not the only option. Okay. So very important that which one what is available, what you are trained with, what are pros and cons, how you do it, and how you get the implant. You know, to date, I know I put bioabsorbable screw. It's friendly for MRI, your revision wise. It's good. It absorbs. You have less problem, but still the interference screw, best one is the metal one. The
Yes.
interference you get out of the metal is still the best one. And for us, it's the blessing, 2,000, 3,000 rupees. So it has
Yeah.
pros and cons. So whatever you do, it doesn't matter. At the end of the day, great presentation, great club. Guys sitting out there, open your mouth. Yes, I have PTB, I have hamstring, peroneus longus for multi-leg. If somebody is coming, quadriceps out of it, we can't afford synthetic allografts. We can only afford autograft. In terms of choice, good tunneling, good surgical technique, emphasis on that. You have to know your anatomy and have to know it's there. Third, a good fixation, whichever works in your boss's hand, in your teacher's hand, adopt and do a good job for the patient. And always a rehab. And that will be my idea. I think I wouldn't go more than 10 minutes. Aisha is very regimental person, and Faz, I don't know, they have a personal WhatsApp going on as well. Hope not. So, I mean, it's fantastic. It's a good idea. Hope these 30 participants will ask a couple of questions from Faz.
There are pretty, there is a lot going on in the chat box, and I'm really happy that people are very keen. So
Yes.
I will actually invite Dr. Rohit Shethar, one of the audience. He has some questions from Dr. Javed Iqbal. So if Saad, we can unmute Dr. Rohit Shrestha. So kindly please introduce yourself as well, where you're from, etc.
Sure, welcome.
Morning, sir. Can you hear me?
Yes, we can.
I'm Dr. Rohit Shrestha. I'm from Kathmandu, Nepal. I like your study very much. It is very informative and very good. And I have a couple of questions regarding the study methodology and regarding the operative technique and its outcome also. So my first question would be, you say you have quoted it as an analytical study in the publication, but you don't have any comparison group. With the sir has already mentioned a little bit on that already, but still I wanted to ask, you would, in my opinion, probably it would be better to call it otherwise than analytical study when you do not have a comparison group. So this is one comment. Another point is sometimes there is complications while drilling the femoral tunnels, and you blow out the lateral cortex, and in that condition you might not be able to use endo buttons and you have to use alternative fixation methods. When you do large series of cases, sometimes complications do happen. Your article probably lack mentioning about some of the post-operative complications and how you bail it out, how you come out. And if those were the cases, did you include it in the study population or not? And one more question on the graft diameter. You said it's a quadruple tendon. Sometimes it's not possible to have quadruple tendon, or it's not enough diameter is obtained by quadrupling also, especially in the ladies, short stature. Graft diameter becomes very thin. We may need to go for pentafold or hexafold just to maintain the minimum graft diameter, or either you standardize to say graft diameter of 7.5 minimum was used or something like that, because graft diameter is related to the strength of the graft and that will relate it to outcome. The fourth question, if you allow me to ask, is about the outcome measures. You have used two scores, IKDC and Tenger Lysome. Could have been used only one, or why you were using two, or and is there any difference between the using two? And the next is some of the question content in that questionnaire is a little bit more towards the Western literatures. It has to be validated in our part of the world. Means some of the question is really not according to what our lifestyle is, whether it's Nepal or India, Pakistan or Bangladesh. In our region, maybe lifestyle is different. Has that been validated in our local context so that it can be more good tool for using in our part? So thank you very much for giving me this opportunity to ask the question. Thank you very much, sir.
So we will request Dr. Javed to go one by one. So first question is, how can you call it analytical study, Dr. Javed?
As I told in the start that we analyze all the variables And doctors have said that there is it's not comparative study. So basically, this is if we go into the hierarchy of the biostatistics. So the comparative study is superior than analytical or descriptive type of study. So if we go into the details of my slide, that is preoperative variables and postoperative, all variables were analyzed and compared with each other. So IKDC score, Tigner-Licholm score, preoperatively that was assessed, post-operatively that was assessed, then that was analyzed by means of statistical tests. So this is basically analytical study. And comparative study, unfortunately, it's not comparative study, but inshallah, it will provide.
Perhaps Dr. Rohit is right when he says classical, the term analytical study is a comparative study. When you look in terms of study designs, when we say in terms of study designs, the word analytical study means a comparative study. So from that perspective, I agree with Dr. Rohit that this is a descriptive case study. From your perspective, the way you have used it, maybe you have used it from the simple English term analysis. I believe both the gentlemen are right in their perspective.
Can I add something for clarity? When you say analytical study in the research arena, you have to have a hypothesis. Something you have to make. My hamstring is better than PTB. You have to make a hypothesis, a negative, a positive, whatever. You have to make a hypothesis. So basically, once you have a hypothesis, not only a word, which shows this is better than this thing. So then with any analytical study, must have a hypothesis to compare with another thing. So that's why he's right in that, but it's okay the way you describe. You're probably okay, as Aisha said, but for the guys, for the participant, have a hypothesis for an analytical study and compare it with something, and then say in the end, yes or no, or it's okay, equal. With the outcome, you have to then show in an analytical study the outcome is better than or worse than this one. Yeah, go ahead. Yeah.
Exactly, sir.
Dr. Aisha, can I add something?
Yes, sir. Yes, Dr. Faz.
Okay. Well, actually, study of Dr. Javed is actually observational. As you can see, there are broadly, if we divide, this explanation is just for the person who asked the question, Dr. Rohit. So actually, two types of studies broadly, observational or interventional. So actually, it's a sort of observational study. And there are certain guidelines for intervention study for observational. For observational, we have strobe guidelines. So under strobe guidelines, Dr. Javed's study, you can see it's a retrospective. And analysis, by analysis, it doesn't mean that it's some sort of comparative or intervention analysis of the variables. So it's an observational strobe, and you can say a retrospective cohort study. So that's why I think Dr. Rohit is confusing it with rather experimental or interventional.
Yeah. Okay. So the second question was, he said that there are, since I'm not a sports person, so I didn't comprehend it really well. So he asked that there is a lateral wall blowout when they use endo button. So Dr. Javed, did you have any of such complications? And he rightly asked that this study does not mention any of the complications like related to wound or method.
Yes.
So can you highlight on this?
Yes, the blowout term is basically made up for the posterior wall, it's not for the lateral cortex. For the lateral cortex, in the suspensory mechanism, what we are doing, we are not completely making the tunnel through and through, means if the graft is 8 millimeter in diameter, so 8 mm removal we are not doing from the interior to the outer cortex. We are doing, if say our aim is to retain up to 20 mm graft inside the femoral, in the femoral bone. So we will ream up to 20 mm, and the rest 10 mm or 15 mm we will leave intact. The intact area will have only a small aperture through which the endo button will pass. So there is incomplete tunnel. Sometimes when a surgeon is doing surgery on the femoral side, they are completely drilled the femoral side through and through, say 8 mm, say 9 mm, or say 7.5 mm from inside to the outside. In that cases, we can't deploy the endo button mechanism, because for the endo button, there must be some area through which the endo button must flip and must retain on the outer cortex. Otherwise, the graft will retrieve and will come inside the knee joint. So the lateral cortex complete drilling, there is one of the complications, but alhamdulillah, we don't have any sorts of complication in our study. One complication, that is, we had one endo button not flipped on the lateral cortex, that has been flipped in the soft tissues. So the day after surgery, when we did X-ray, we found that the endo button is not sitting on the outer cortex. We reoperated that case and we flipped the endo button on the outer cortex. Coming toward the posterior wall blowout. The posterior wall blowout, that is very disastrous complication. So in that condition, that is basically, as sir told, that the main important thing for the superior outcome is the anatomical position of the femoral side tunnel. So if you blow out your posterior wall, it unfortunately the results will be substandard, but we have to fix the graft in that condition. Alhamdulillah, we don't have in my 1.5 year super specialty sports program, we haven't
Okay, Dr. Javed, yeah.
fixed by means of aperture or by whatever method.
Okay.
I think I will again add for simplicity. You know, the trouble is that the participant gets little confused. Is done exactly, I understood nicely, and is done exactly what he's saying. So don't mix two things. The endo button need insertional length with the size of the graft, and then they have a 4.5 drill. The size of the graft can be anything, 8, 9, 10, whatever. So insertional length it calls, which is inside the femur. And the rest is where the endo button pass, which is 4.5 millimeter, and flip on the cortex. Blowout, if somebody is doing ACLs for, I mean, for a long time, if you haven't done a blowout, it's a wrong statement. You haven't done enough ACLs. Blowout is just going from the posterior cortex. And for a good news, the endo button cannot be placed in a blowout. If I have a blowout, the interference screw cannot be placed because you have a blowout. Blowout means the posterior cortex is gone. So you have no hanging there now, no insertion there. So no interference screw will hold that. Even in that situation, endo button will bail you out, and you can make a supplementary fixation. If you're worried, supplementary. By the way, just for the, again, participant, I really love my participants. So see, I try to make it simple. Actually, your weak link in the graft is not the graft, which is 3,000 to 4,000 Newton. Your grafts are stronger than ACL. It's your fixation. And you know which fixation is the weak fixation is actually tibia. So blowout still happen, but you can manage the insertion with one wall missing. But if you can get your button out, a decent 10, 11 millimeter out of the lateral cortex, you can still manage and save that complication. So thank you. I don't want to delay, but I just said for the guys sitting there, don't be upset if this thing happened, you know.
Yeah, thank you for adding that. So there was a third question. So again, I just want to mention, I'm not a sports surgeon myself. I'm just doing the moderation. So I might not put forward the question properly. He also asked that sometimes quadruple graft is not sufficient. We need sometimes pentafold or more to maintain the diameter of the graft to at least 7.5 mm. Outcome may differ with the strength of the graft that is proportional to the diameter. So I'll put forward this question to Dr. Kamran.
Yeah, very good. Yes, there was always a discussion about, he's right, it's actually called this, Rohit has made a comment. It's been bigger the better, okay? We know in orthopedic, we like a bigger screw. 4 is better than 3. So obviously minimum 7 to 7.5 with good fixation. But now they're saying the tunnel position. With the good tunnel position, surgical technique is also very important. Yes, you have to have a minimum of that. So this is only kind of comment. Yeah, I agree with If you don't get the adequate site, there's no point putting, something which is not going to hold. So that's fine. So I think we should move on. Yeah, you should have a good, at least 7 with very good techniques. 7.5, okay, but surgeons do fight on it, but bigger the better. Answer simple is that, But
Okay.
surgical position of your tunnel, anatomical, don't go anterior, don't go vertical. Anatomical, don't be afraid, go behind, look at for all those markers. Anatomical, biological, individualized, ACL, good fixation. Everybody take a patient as a symptomatic instability. He is not a painful patient. Make him stable. Look at all those factors. So again, that's why I'm saying popular, today's choice is popular, anatomical, individualized, biological, good fixation, ACL. Thank you.
Yes, sir. And the last question from Dr. Rohit, maybe he can ask himself. Dr. Rohit, can you unmute yourself? And I think there was a last question about the 2 outcome scores that are used in this paper, as Dr. Javed mentioned.
There was IKD and madam, that is remembered to me. Like, first of all, I would like to say a few words about the graph dia, as sir told. What we are doing when the graph dia decreases, when 7 mm are less than 7 mm, what is our protocol? We add fiber tape. We add fiber tape when the graph dia, we get dia less than 7 mm, when the patient is hyperlax. That is when the patient is hyperlax, and when the dye is less than 7 mm, definitely that graft fails with the passage of time. So we add fiber tape, which is basically an internal brace to enhance the strength and the stability of the graft. And coming toward the last question of the Dr. Saab, that is, what is the difference between IKDC and Tigner Lifetime score, and why we are adding 2? So if you go into the detail of that, these 2 scores, definitely there are some points which are basically overlapping with each other. But in the statistics, if you apply more scores, and so it increases the strength of your study. So IKDC and Tigner Lifetime score, basically this is for the ligamentous injury of the knee joint.
Okay, thank you very much. So we don't have any further questions. We had 32 participants. So we have 5 minutes before we end. So if anyone want to comment or say anything, they can raise their hand and we can, unmute them and take their comments. So I have one question. Why did you include only men in your study? do we don't have any female sports persons with ACL injuries? This is a very dark picture.
Yes, madam. Very interesting question. During my 1.5 year fellowship, I encountered only one female who got ACL injury, and we reconstructed that ACL injury. Sorry, we repaired that. And I interviewed her yesterday after 1 year follow-up. She said, I am doing well. There is no pain. There is no instability symptoms. But in 1.5 year fellowship, I haven't seen, apart from that single lady, I haven't seen any lady with complete ACL injury who wished to undergo ACL reconstruction.
Well, Dr. I would like to ask Dr. Kaman, is there any reason in your practice as well that why it's not common or it's ignored, or there are some other reasons? Because it's in studies you have to balance all these things like gender bias. So is there any, would you please comment?
Yeah, very, very good. See, first of all, we don't have our statistics. I'll start with statistics. In America, 200,000 per year ACLs are done. And anybody who's playing for 5 years has to have strong ACL injury possibility. Anybody who's actually playing. So in our society, unfortunately, female sports are not considered a good thing. I'm with Pakistan cricket. I asked a very stupid question once. I said, our female cricket players, nobody come in the stadium. They took me out from the meeting. They said, Doctor Sahab, ye kya kar rahe hain? Aurton ko mard dekhne aayenge. So I was shocked. The girls are playing cricket and you want blokes to come out. So this is sheerly lack of participation. People love them to be married in 20s ASAP. lack of sports, lack of presentation. And mind you, our presentation of patients are a lot less than it should be. Our parents will discourage you. Anybody have ACL tell you, this is end, you're not playing anymore. Well, I do surgery for return to play, return to sports. It's sheerly cultural. It's sheerly the gender bias. Is the sheerly the society. The women have a different role, a housewife, quickly getting married, not sports. We have girls who are in the sports, who are tend to be very, very few. There's not many. So it's very, yes, you do get them, but the sports they play, and the second thing is the sports as well. Dr. Saab mentioned things, you know, the Western sports like soccer, football, pivot sports, these are the one the ACLs are problem. Our sports like something like cricket and these, they are actually upper limb. They're mostly shoulder problems. So that the really an ACL injury has to be a very awkward bowler who twist and pivot and shift in this one. So the multifactorial, if I ask scientifically, first of all, the participation level, the incidence, presentation level. Number three, the sports they play, they can be getting them boys. Have you seen any girls playing soccer? Yeah, you haven't. No. So have you seen them? Yeah. So very few. Look at the number of sports. You teachers, doctors. What else? If you get a one pilot, you put it on the picture. Oh, one girl has become pilot in the history of 220 million people. Well, it's bad.
Or
We
one
need more
woman
Aisha. You know?
orthopedic.
Yeah, we need more Aisha. We need more Aisha. Look, she has done a wonderful job, you know. I mean, she's and Faz, Aisha, all those people are bringing these forums. I mean, it's wonderful. But the main thing is that I think there is a clear bias in our attitude and other things. We are, as a nation, we have to be involved in sports. I think our participation in sport is very less. And the woman, by and large, is minimal. And that's the reason, you know.
Okay, so with this very nice note on diversity and inclusion, we end this very productive journal club. We don't have any further questions, although some comments that it went really well and they understood a lot. Dr. Naeemullah mentioned that, and Dr. Faisal Nazir was there as well. He also mentioned that he enjoyed the meeting a lot. So this was also going on as Facebook Live. So any of you who couldn't attend at this moment can actually go back and see the recording. And I'm sure you will have plenty to learn. So I will really like to thank Dr. Javed Iqbal and mostly our expert, Dr. Kamran Butt, for adding, you know, color and all the glory to this journal club. And we wish to see him more in our future activities. So thank you all. And we will have the final leaving comments from Dr. Faz. And with that, we will end the meeting.
Well, thank you very much. It was really a nice presentation by Dr. Javed, and I'm really thankful to Dr. Kamran. He's a busy person and just came from traveling and gave us time. And actually, the purpose is to promote the super specialty as well. Dr. Kamran is well aware that we haven't so many arthroscopic surgeons, and particularly female, Dr. Aisha, female orthopedic arthroscopic surgeon. So at the end, I'm really thankful to Dr. Kamran, Dr. Javed, and Dr. Aisha. Thank you all.
Thank you so much.
So see you next time. Thank you all. See you next time, next month, inshallah. Khuda Hafiz.
Thank you.
Thank you so much. Allah Hafiz. Allah Hafiz.
Khuda Hafiz.